Good afternoon. My name is Chris Hollingsworth. Today I'll be presenting on benign myoepithelial neoplasms of salivary glands, a clinicopathologic profile and literature review. These are my learning objectives for the talk. With regards to myoepithelial cells in health, they are a ubiquitous functional component of mammalian exocrine glands found all over the body. They are epithelial in origin, and they are located between the basal lamina and the acinar/ductal cells. Their main function is contractile, helping glands excrete whatever substance they're producing, but they also have numerous other functions. With regards to understanding how myoepithelial cells fit into benign salivary gland adenomas, you have to think about it on a spectrum. So myoepitheliomas are tumors comprised entirely of myoepithelial cells, where on the other end of the spectrum you have basal cell adenomas, which are comprised of the epithelial ductal component. And in between, you have a range of pleomorphic adenomas. The differentiating feature between a pleomorphic adenoma and a myoepithelioma is that the ductal/epithelial component is less than or equal to 5 to 10%, and there's a lack of chondromyxoid or fibromyxoid matrix. Histologic diversity is a hallmark of myoepitheliomas. And what do I mean by that? These tumors can present in a variety of ways histologically, resulting from the interplay of three major characteristics, being the cytologic differentiation. This is the individual appearance of the myoepithelial cells in the tumor, the extracellular matrix production, as well as the architectural patterns of the tumor. The cytologic differentiation is how a pathologist will describe the individual cells. Are they fusiform and spindle? Are they plasmacytoid? Are they full of glycogen and appear clear on a slide? The architectural patterns are more a description of the superstructure of a tumor. This is a very rare tumor, making up only 1 to 1.5% of all benign salivary gland tumors. Due to this, there are many individual case reports, but very few case series or reviews, especially of this magnitude. The value of this article really lies in the scope of our data set and the clinical pathologic overview it's able to provide. To the best of our knowledge, this is the largest single center case series of myoepitheliomas. This project is targeted at clinicians and pathologists who encounter and manage head and neck pathology, and we hope it'll contribute to improved differential diagnoses and patient outcomes. With regards to our case series, we pulled 13 total cases of myoepithelial salivary gland tumors from the DCG oral and maxillofacial pathology archive. 4 are benign myoepithelial carcinomas included for comparison's sake, and the other 9 are benign myoepitheliomas. Our comprehensive literature review yielded 139 total articles scraped from PubMed using the relevant search terms between 2008 and 2023. We, after imposing our inclusion-exclusion criteria, settled on 32 articles yielding 34 total cases of myoepithelioma in the head and neck region. So our data analysis and our statistical methods. With regards to our DCG institutional data set, our age range was 24 to 76 with a mean of 50. The literature reports that this tumor presents in the 3rd decade of life most often, which really fails to illustrate the variability in age at which patients can present with this tumor. The gender ratio in the literature is evenly split. It's said to lack a gender preference, which is what we found in both data sets. With regards to presentation site distribution, the literature reports a 40% parotid involvement. All our benign cases in our DCG dataset presented on the palate. So this is a pretty large discrepancy. This discrepancy can be attributed to the fact that the DCG oral pathology service receives outpatient cases. Somebody who would get a parotid biopsy would likely be under general anesthesia in an OR, and their case would be processed through the hospital service, which explains why we don't really have that many parotid cases. With regards to a general clinical profile, myoepitheliomas are typically an asymptomatic, slow-growing, well-demarcated, non-invasive lesion, but that can vary, and I'll speak on that a little bit later. With regards to clinical indicators of malignancy, pain, irregular surface ulceration can point towards malignancy, but they're not pathognomonic. You can see in this data set, ulceration was seen in benign and malignant lesions. With regards to the histology side of things, our most common was plasmacytoid hyaline, followed by epithelioid and spindle. 75%, 50%, 50% respectively. This does not add up to 100 due to the fact that these tumors will present with often 2 or more cell types in the body of the tumor, described as a mixed cell type tumor. The literature reports 12.5% of tumors are mixed cell type. We found 63% of the tumors contain 2 or more subtypes, so significantly more. Most common stromal architecture was fibrous. Necrosis and mitosis were limited to malignant cases, and the only statistically significant finding was the presence of mitosis with a p of 0.001. With regard to our literature review, you can see the demographics are similar. The age range is slightly wider. The palatal sites exceeded the parotid sites in our literature review, combined 35% compared to a parotid 23%. The literature reports 93% of cases of myoepithelioma found intraorally presented in the minor salivary glands of the palate. So there's some discrepancy in the literature as well, and I attributed this to the rarity of the tumor class. With regards to clinical symptoms, 74% of the literature review cases were asymptomatic, and the 25% that presented with symptoms included airway compromise, pain, and difficulty speaking and swallowing. This is just a summary, once again, of the histology side of things with regards to our literature review. The World Health Organization classifies myopathy as more aggressive than pleomorphic adenomas due to a higher rate of recurrence. Benign to malignant transformation has also been noted. Because there is no pathognomonic sign, diagnosis is made via a constellation of signs, symptoms, histopathology, and imaging in order to reach a definitive diagnosis. The best imaging modality is contrast-enhanced MRI, with definitive diagnosis only being confirmed after biopsy. The suggested management is surgical excision with a margin of uninvolved tissue. Regular follow-ups are recommended due to the high rate of recurrence mentioned prior. Recurrence can be up to 15 to 18%, or as low as 6%, depends on what source you look at. Of our institutional cases, 33% were recurrent cases. In conclusion, I want to thank everybody for their attention and for coming to this talk. It's important as dental professionals that we work in proximity to the glandular structures of the head and neck, and we should recognize this as part of our differential diagnosis in order to help deliver adequate, timely treatment and improve patient outcomes. Thank you.